Hi, everyone. I'm Ashley Bassett.
And I'm Catherine Logan.
And welcome to the Sports Docs podcast. On each episode, we chat about the most recent developments in sports medicine and dissect through all the noise so you know which literature should actually impact your practice. Today, we're coming to you live from the American Orthopedic Society for Sports Medicine annual meeting in Denver, Colorado.
The AOSSM meeting is a premier sports meeting conference each year, hosting over 3,500 attendees with hundreds of poster and paper presentations, exhibitors, and instructional course lectures. This year proved to be as spectacular as years past. We were fortunate to have the opportunity to catch up with many of the presenters at the meeting and get their take on some of the hottest topics in sports medicine.
Over these 8 episodes, we're going to be exploring some cutting-edge sports medicine with these experts who are presenting at the AOSSM annual meeting. Today's episode is going to focus on patellofemoral cartilage restoration and discuss osteochondral allograft transplantation for both patellar and trochlear lesions, as well as off-the-shelf options, including Arthrex Cartiform. We will also chat about the addition of osteotomies to offload that cartilage restoration and optimize outcomes.
We are joined today by Dr. Tom DeBerardino, a professor of orthopedic surgery at the University of Texas San Antonio, team physician for UT San Antonio Athletics, and a retired U.S. Army veteran.
So without further ado, let's get to the field house. Treat articular cartilage defects in the patellofemoral joint and beyond with the Arthrex AutoCart technique.
This single-stage, matrix-augmented autologous chondrocyte transplantation combines the patient's own viable cartilage collected with the GraftNet device with biocartilage extracellular matrix and Arthrex ACP to treat full-thickness chondral defects arthroscopically.
Harness the benefits of viable autologous tissue. With the GraftNet device, collecting cartilage is as easy as resect and collect.
Learn more about AutoCart and other Arthrex cartilage treatment options at arthrex.com or at orthopedia.com. Okay. All right. So welcome to the show, Tom. We are so excited to have you join us for this special episode of the Sports Docs podcast live at the annual meeting in the field house. So welcome to the show.
Great to be here, both Ashley and Catherine.
Thank
awesome.
you.
I've been looking in from outside with great anticipation.
Awesome. Well, hopefully we live up to your expectations.
I'm sure you will.
So numerous techniques have been described for cartilage restoration in the patellofemoral joint. And normally we start with like workup, what do you do, everything like that. But in the interest of time, we kind of want to dive into surgical aspects of it. But before we do that, we want to talk about the role of staging arthroscopy. So how often are you doing a diagnostic arthroscopy for your cartilage patients? And is there something specific you're looking at, and how are you doing that diagnostic arthroscopy?
So in the modern age, right now, I just got a new surgery center, kind of state-of-the-art cutting edge. We have the new Arthrex Panoscope, which has the nanoscope.
Nice.
I can either use the large joint if I'm doing concomitant staging for like multi-lig or meniscal work, or I can use the nanoscope. And the nanoscope is that small needle arthroscopy technique that gives you a 4K image. You know, it's a square box instead of a round view, but you can see directly ahead in the patellofemoral joint specifically. It's a stadium view to begin with. It's the clearest spot. That's why we go up there with the scope. So there's no concept or problem seeing through the sea anemone of a fat pad and all the different stuff that's in our way in the front of the knee. And you don't know if you're in or not, and you don't have to insufflate as much fluid to overpressurize. You can do it very quickly. It's very low morbidity. Patients localize the portal and then just poke in. The patient's always 100% awake, not sedated, nothing. They're looking at the screen live, and you're going through it with them. So even if they don't know what you're exactly doing, there is that innate understanding that they can see something and they can visualize it and very objectify it. So that's great for staging. I have to do a staging scope unless there's a reason not to. If I have a prior fellow or a colleague in our community that knows what they're doing and gives me great pictures, because I use it to validate the indications. We know clinically the indications, isolated, focal, well-contained, unipolar ideally. But in my world of revision, sometimes they're bipolar. We don't advertise for that. Those are one-off cases or salvage cases. But in a 22-year-old, they don't want plastic and metal, and I don't want to give it to them. So we do everything we can to do weird things to weird problems. And OC allografts, why OCs? So we'll get into that in a little bit, I'm sure. But we use that nanoscope now. It's in the pro sport level where time is money and money is big. A nanoscope is the definitive source documentation for is he ready to return to play? Functionally, psychologically, sure. Radiographically, sure. How about looking at it? That's how we got
Right.
here. Why don't we leave there by going, it now looks fine?
Right.
Because if it doesn't look fine, it probably isn't going to do fine. And it gives the whole community of onlookers, coaches, people, NIL in college, and agents, and family,
yep.
and players, that little more certified qualification of it's as good as it can get. It looks darn good. Go for it. So
Right.
it's the final definitive answer to me.
Yeah, I think the nanoscope, initially I was using it actually more for like ankle fractures, sort of peeking in the ankle joint and just thinking, okay, that's really quick and easy if I have a little loose body to come out. And it's become a larger part of my practice over the last probably year and a half, because it does have a lot of utility. And what I really also like about it when you're doing those diagnostic scopes, when you're doing them standardly, you still like the quad just shuts down.
Yeah.
Yeah.
And you're like, we didn't even really do anything except like
Right.
take some photos and maybe do a little cleanup. And their quad is just totally diminished.
It's a big price to pay. If you just want a
is.
picture, I mean, if we stand together for a photo, it shouldn't hurt.
Yeah.
Right.
So,
totally.
I mean, this
Yeah.
literally is a Band-Aid. I mean,
That should be a tagline.
Yeah.
My photos don't hurt.
Yeah.
And they get to see it real time, and there's something about seeing a video versus a picture. Because if I show a picture and it's not mine later, and I go, oh, look,
Right.
this is Catherine's scope pictures, I go,
Exactly.
Yeah.
but if it's a video, you kind of get the context
Yeah.
environmental, and you're like, okay,
like a
top,
story.
that's up, that's east,
Yeah.
that's west, and it's a storybook, like
Yeah.
a good comic.
Yeah.
Yeah, exactly. Exactly.
Yeah. Go ahead,
Awesome.
Ashley.
So now with that, we do want to move on to surgical techniques. So
Yes.
as I said, there's a variety of cartilage restoration techniques that we could talk about, but you doing a lot of osteochondral allografts over some other options like cell-based therapies. Can you tell me why?
You know, in 27 years, I started when I got out of the door out of HSS and West Point. They kind of worked together when I did my fellowship back in 96 and 97. I only did OC allografts for patellas. I've never done anything but to be open book and as biased as that is, because I initially was doing revisions as much as primaries. I was the tertiary referral sports guy doing cartilage work at BAMC in South Texas and San Antonio when I was still in the Army. And there was nothing to go to in a revision setting other than an OC. And they did so well, I immediately backtracked and said, well, my primaries they get
Revise.
why
Yeah.
they're getting a revision-like setting.
Yeah.
I'm going to do that primarily because it's very robust. You can walk on it right away. It is real cartilage. It's living cartilage. You get it through the companies, JRF and others. You know the quality because
Right.
they check it to the hilt. It's certified. It's tested more ways than I know they do. I've been to their lab. It's awesome.
Yeah.
It's a higher level of sterility than any of our ORs combined. But so that's the technical part that's sells us for the safety piece. The durability and the utility is amazing because I don't have to wait on the patella OC or the trochlea, but the patellofemoral in general, but the patella specifically for our discussion, to be the rate limiting step for progression and rehab. It's just coincidental. There's phase 1, 6 weeks. They're full weight bearing. That's not the limiting. They never have not been full weight bearing in my life. I put them in a brace, but they're full weight bearing. Locked in extension because that doesn't engage the patella. We engage the patella in motion separately, but we don't let them walk together because if they did fall, they could get a fracture. Everyone falls. And I go, do you have a brace on? I don't care about your nose or elbow. How's your knee?
Exactly.
So we all do that.
100%, yeah.
But the technique is simple, straightforward. It's like I tell the fellows, it's like building a birdhouse. Don't freak out on me. We're just going to make one cut, and it's a press fit. It's a cork in a bottle. And then they go, okay. Make the cut.
Exactly.
Well, I think that perfectly moves into what we want to talk about, your surgical technique. So I have personally watched your videos that I've seen on LinkedIn. I know Ashley has as well. They look very magical.
Yes.
And
It's a good word. That's a good word.
so they do. They look excellent. And so we really wanted to sort of distill down technique. And especially, for the patellofemoral compartment, because it is a lot trickier than just doing a standard condyle. So can you really go into the deep details of your technique?
So you're in there, you open up the room. The first thing you got to do, obviously, we all check the patella to make sure it's a right patella for a right patella, because you can't believe how many times that's an unforced error. And I tell the fellows in the hospitals, that's the most important thing.
Yeah.
When I get to the hospital, I check the boxes. I look at the label, and I look at the patella. It's hard because it's in the milieu of support fluid. I won't go into details there. And you have to make sure it looks like the human I'm going to put it in. Like if it's really small, it'll fit a fine in a small person. But if it's really small and it's a defensive tackle, I kind of go back and go, wait a second, before they get an IV in the pre-op area. Everything's copacetic. Not only the correct, because I have to be able to get what I call a mega patella out of this thing more likely than not. So size, check is the most important thing. I've checked them on an app, actually on my phone, it's a text, and I look at it, I physically look at the picture from JRF, and I sign off on it, and then all the people in the background do all the administrative approvals, but I sign off on the patella that's coming FedEx. And that's so critical. We kind of
so important to be
pass
part
it
of
off
that.
because there's a lot of people. There's the place you're getting it from, JRF in my case. There's us receiving it. You got to know not to put it in the freezer versus the refrigerator. That happens if it comes in on a Sunday and you got the C team covering on the weekend.
Right.
Oh, all the boxes came. They're in the freezer because they're menisci and tendons. And you're like, oh, the patella goes in the refrigerator.
Yeah.
Exactly.
So
You have
that's
to be
critical.
involved.
So
Absolutely.
then I open up when the case opens. I immediately open the patella because it's definitive. We're doing it. It's not like we're going to give it back. You bought it. You own it. I check to make sure. Then we're talking about the fourth dimension. What's the keel of the patella look like? Is it, you're looking down at the surface of the patella. Does it match the shape of that person's patella three-dimensionally, not size? That's been cross-checked by AP and etiolateral dimensions radiographically. Then you got to take into account the shape of the patella. Because then when I go mega patella, it's akin to a PFA patella button. The new patella is the patella, the functional patella. So I go as big as your patella can take it, unless there's a reason not to, like an isolated lateral facet, the rare medial facet, which some people say, and Brian and I agree, you can almost blow off. So they're usually central lateral facet. And we go as big as we can with a 2 millimeter margin. And I tell patients, your patella is a clay vessel that I'm putting a new fern plant into. And that's your beautiful, rooted, bone-plugged cartilage, full-thickness cartilage. And it may not fit in every dimension because if your patella that you're getting is this big and it matches the trochlea enough, we don't match that on the, the
Pre-op imaging.
Chinese menu that has all the different options. We have we have sizes and gradation of cartilage damage. Hopefully it's 0 or maybe 1 in certain areas that we're not using. And that's it. That's all we do. We don't account for the three-dimensional shape variances. So what I'm saying is if it sticks up at the apex a little bit, it's okay because it is the new patella. Sometimes I'll take a 15 blade and just taper the edge of the 5 millimeters of cartilage. But it's not always going to be a perfect fit when I close my eyes and run my finger on it. So that's working backwards from the final product so people don't get scared and they start pounding it. Because if you pound it, it's a block of ice. It will crack because metal versus cartilage and bone, it's going to crack or you're going to get a wrist injury because you can't hit it that hard. We often use on the reduction part, skipping ahead from the back end, but you got to know how to get there. No, I'll use the trochlea as the best positive tamp. It's cartilage on cartilage, and I'll tap the back side of the patella as I'm moving it through an arc of motion. You'll never over-reduce it, but you'll just get it just right to fit the trochlea, which is really the goal. You want the patella to glide in the new trochlea, or the trochlea if you're not replacing it.
Yeah.
So how do we do that? We get our guide, and it's always guide pin placed on the recipient sock, and we take the patella, I make a line. That's the most important thing. I draw a line. That's the apex of their patella. Even if it's flat, you have to kind of go, it's always off a little because you flip it and it kind of goes like this, and you have to go, that's the ridge line. That was the apex of their patella that's not there now. You draw that. You can always kind of tell within a millimeter. And then I put the pin through the block. It's a semi-radiolucent block. It's a tube. They're cylinders. They come in the Arthrex set now. It's a great set. It's got variations, I think, at 2.5 millimeter increments. It goes 22.5, 25, 20, and I use 30 and 35, so I don't even know the smaller sizes. So we're going big. So we put the pin through it, and we put it on the blue line, and I put it down. I go, then the most important thing is to get the plane right, and that's the pin in the cylinder. You have to make sure you're not going to dive deep like a manhole cover on 2nd Avenue that doesn't fit on 1st. It's going to not really fit. And you got to go into it equatorially. So I kind of have 2 people holding the quad and the patella tendon with towel clips, and I fine tune them when I say freeze. That's level. Then I've got to just match the levelness in every plane, medial, lateral, and up and down. And that's as horizontal or perpendicular as I can get to that plane, because that gives you the best chance to get the tapered edges, which are the least amount of bone, full thickness cartilage, but you want 2 to 3 millimeters of bone. In fact, you want a hint of cancellous bone because cortical bone doesn't heal great, and you might get a residual cyst or just a malunion looking issue there. So you got to penetrate enough into the medial and lateral edges so that when I look into the recipient socket after we drill it, I don't ask what the depth is first. I say, how much bone, because I'm on the back table preparing at this point, how much bone do you see at the 3 o'clock and 9 o'clock position? And they're like, there's plenty. I go, no, measure that. And then tell me the quadrant measurements of the total depth, because I'm going to cut total depth on the matched quadrants on the plug on the back table. But while they're doing this, we score the cartilage with a sharp blade, and we auger it out over the guide pin, and I stick the guide pin right through the back cortex so it can't move.
Okay.
I mean, it's got to be
solid.
Solid. Then we tamp it with a dilator to make sure it is a good bottle to receive the cork on the back table. And then we actually drill it. This is the most important thing I've come up with in the last 12 years. I call it retro drilling. There's an actual official term, and if you ask me to spell it, I will not spell it twice the same way. Canaliculation.
Yes.
One of our smart fellows looked it up, and I go, "Are you sure? You know I'm not going to check you because I don't even know how to do a Google search." I'm like, all right, canaliculation. 1 L or 2 L? I don't know. But it's 1 L. That I know. I get lost when I spell it. My thumbs don't work on my phone. So that is the most important thing for 2 reasons. We drill the recipient socket to get good bleeding bone. We know in a difficult old patella that we got good bleeding bone. That's the nutrients coming into the roots of the fern plant we're about to put in the clay pot. Going back to my plant analogy. On the back table, I've gotten the patella into the Arthrex jig, and it's industrial. It can't slide off the table, because if it did, it'd crush your foot. You'd have a Liz Frank injury. It's
a different problem.
a sled. It's there. You have to pick it up and move it. Otherwise, you'll move the whole back table. So that's a vice set system now, and it's got a 6 degree of freedom arm that comes in and lets you target the recipient patella that's clamped in with special little guides so that if you're taking a mega patella, you're going to go right to the edges of the patella. So you have to put it in the vice so that you're only compressing it where you're not going to be cylinder cutting it out with a cylinder saw. So we cylinder cut it right out. I go right through to the bottom, and I lightly turn the whole jig over, which has got a tamp with a little grommet in it, a metal grommet, and we just lightly tap it out. We're not pounding it. It's hand surgery. It's not orthopedic surgery. We tap it out, and I have my hand over it, and it just comes out like a cork out of a bottle, very slow, and trying not to do any damage to the cartilage. Then we get it, and we go, what's the quadrant measurements? So if they aren't up to me at that point, they're really slow on the patient bed over there, right? So then I say, and we go 12, 3, 6, 9. Usually I do it real time. There's no writing it down. I'm like, live count. What's the 12 o'clock?
Yes.
We mark that at the 12 o'clock position on the graph. And we've already pre-marked it at the top of the circle because it's a circle. You're like, where am I? You kind of can tell. You can tell 12 and 6 and 3 and 9, but you could get it backwards. So we have a little slash mark on the top of the patella. We flip it over. I don't even have it in the vise. I've just wiped it off, and I put a little ruler. We cut it down, and we just measure from the cartilage into the bone, the quadrant measurements, 12, 3, 6, and 9. Then we cut across it. Then I rongeur the edges so that, what's the hardest thing, getting a cork in a bottle? Sometimes you chip off a piece. So they're thick enough that I can chamfer the edges with the rongeur so that I can safely, so it doesn't shoot across the room, I can press fit it in and go, it fit fine. I can look at it from every angle before I start tapping it in and make sure I don't go in eccentrically. I want to go in straight, so I don't have to. You can pull them out. There are ways. We can talk about that at the end if we have time. So then we don't just press fit in. So I rongeur it out, and then I retro drill. And we were talking last night at a cocktail party. We drill the heck out of the back of it so that when I always put the plug up to the xenon light, and cartilage side, cancel side to the light. You can see a million little drill holes. They don't come through the cartilage of the cortical bone, but they go right up to it. So we're very careful with patellas. I drill down in the middle first, where I know it's about 10 to 14. Then I set the drill so that it's a drill press. I go all the way in, so I'm not just faking it. I'm getting into the Oreo cookie center of that plug for 2 reasons. It's canaliculation, ingrowth and healing. And the other reason is that, by drilling deep into the center, that's where the cysts probably come from that we all see. And to negate that problem, I've drilled into it. So now I'm using pulse lavage for 5 minutes, a bag, 3 liters of fluid, and I'm Stanley Steamering that thing out. I'm pulse lavaging it out. And I think before we used to, this is a word they say, I always make up words, it condensifies the bad sound. We're pounding it in and making it go all the way. But now we have drill holes, access channels that I can get the pulsed water in, the pressurized water, and it has an access in and out. So I know we get more of it out. We're going to quantify it in the lab, I promise, in the next year, because I've got fellows now again. And as important as that, so that's a detergent activity. And then we use wall suction. We take the raw tubing and and it's like the drying cycle. When you see water going around, like I thought everything was dry, and there's still water on your dryer. You get everything out you can, because that's all the fluidic component. It's the residual marrow elements. And then you drip in, I do ACP and PRP.
Okay.
Some people use BMA. You know, talking to the people way smarter than me, you two, they tell me that ACP and BMA are equivalent clinically. I can't tell the difference, so I don't want to upcharge someone if they have to get a bill and say, why'd you use BMA if you said in all the things you talk about on podcasts and papers
They're listening.
that ACP
They are listening.
is good, and they know, and they get charged, because hospitals, want to offload as many things as they can until it gets approved. We'll put out a paper in the next year or so with a big review saying canalocalization, ACP, PRP, and pulse lavage. We haven't had a cyst in 10 years. We have not had one. We look diligently. And it makes them heal quicker. It doesn't make them last longer. Can't say that. But it's all about getting people back to their game, their life. And if it heals quicker and there's no cyst, I'm a simpleton. It's probably likely to have a better clinical chance of success.
That makes sense.
Makes sense.
So that's the short of it right there.
That's great. Any other questions about that?
You were talking about, what if you don't like it and you want to take it out?
So if you're on the way in and you're like, oh no, there's a lot sticking out and there's not a lot of hole left, like somebody measured wrong, you can get a coker and just grab it on the cortical bone, hopefully not the cartilage, because you can rip that off and shear it off. And you can just shake it back. It's not orthopedics. You don't want to pound it. You just kind of squeak it out like a cork, like you don't want the champagne to go everywhere. You just kind of work it out slow. You can come from the opposite side if you have to. I did this once right after I had 6 people in the OR visiting from like Japan or something, and I was like, oh crap. They had me leave, go to the other room, go see watch Dr. Burkhardt.
Come back.
And I flipped the patella over, and I drilled a hole through the top of the patella, and I got 2 holes in, and I took the back end of a drill, the blunt end of a drill, and just tapped those out. And
That's a good trick.
no one
That is
knew.
a great trick.
Nobody knew. It just looked like I over-canalicalized the whole patella. We went a little deep. But I used it, and I go, oh, there's drill holes in it already. Who's going to know? But it functionally was, it's how I tell fellows when they call, they go, what do? I go, flip the patella over, drill it, and then poke it out. You can come in from the side, too, like we do to get OCs out of condyles, and I'll take a freer through the saw cut, and I'll just lever it out, and then just enough so you can get a lip on it, and then you can do the oogie maneuver with the coker on the normal side. You don't have to tap it all the way out. You just get a little bit of a breach. And that's it. That's all the safety things. If you drop it on the floor, Brian Cole he'll talk to you later. He's going to talk to you about his chlorhexidine wash. It's like 0.0001, so it's very diluted because you don't want to kill those cartilage cells.
Correct.
People paid a lot of money for those. And there's the donor family, too, the gift of life.
The honor.
So you're going to use it. And I've dropped one as a whole patella on the drape that was trailing off. And we're like, all right, here's what we're going to do. I'm going to grab it with instruments. I mean, the patella was shining up. It just slid down. You're like, whoa, stop. And it was on the sterile drape. We just put a 3/4 sheet on. So I do that all the time now because there's more blue drapes. It slid down. We grabbed it, and we didn't do anything to it. I washed it off, changed gloves, everything. I took it like I was taking a sterile component of a lightly non-sterile field. And I just drilled out the middle of the patella, threw out all that stuff on a separate table, and started over. It was good. But there's different ways. You don't have to freak out.
I don't know, Ashley, if I've ever told you this story, but so when I was a fellow with Proventure, he would have from the back table to the patient, he would put this like blue drape, and he would walk, or we'd have to walk over the blue drape. And then I went back, a couple of years after fellowship to do a case with him, and there was no blue drape. And I was like, what happened to the blue drape? And he's like, oh, the fellows are so much better now.
Kidney punch.
I know.
That's a kidney punch.
I was like,
You walked right into that one.
I did.
Oh my gosh.
That's brilliant.
It was pretty funny.
Yeah, anything you think of for the safety. It's all about, how do you negate the unforced errors? And in OC world, there's no alternate graft source.
No.
It came in a box. You open up this like beautiful patella in this case, and you're like, whew, okay, everybody needs to know the patella is over here.
Right.
Nobody, texts change out during cases. That's an issue. So we put like, we put a, it's definitive. It's like, stay away from the kryptonite. That's no touch. Once it's there, it's ready to go.
Exactly.
But we're so fast now. there's no time to change techs out.
Yeah.
So that's good. And we do all that in like 20 minutes.
Yeah.
I mean, it's just a,
We're
it's
gonna
like an
come
indie
visit.
pit.
Yeah. Yeah.
It's an indie.
But I feel like it's repetition, right? You
It
can't
is.
if you know exactly where you're walking with that. Like I always, when I'm carrying the ACL graft, I always look. I know exactly I'm going to see
Right.
that green thing on the ground that sucks up all the water, and I walk. If you do the same thing every
High
time,
step.
you're less likely exactly high step. You're less likely to have, if you're always grabbing the graft and it's
Yeah.
not your assistant, you're less likely. But the minute you say, "Yeah, go grab that," it's their first time.
The
you know,
freak out
it's-
points for me, things have slipped out of my hands, so you do it over a surface that's bigger than your hand. So
Yeah.
you have the table, and I have containment. I build like a fort. I have like, or boxes of stuff, and I go,
Yeah.
okay, I'm in this little U.
Yeah.
Nothing can happen to it. And I do have people stand there just to, because I've
Yeah.
literally squeezed one like a watermelon seed.
Right.
And my life flashed before my eyes as I'm like walking to the right, and I'm like,
Catch it.
it's an out. The batter's out.
I do.
And
the-
people are like, oh. And it
The-
happens once a year because I do like 100 of these a year, and it's going to happen again. But
Yeah.
you kind of mitigate it by going, okay, that we defeated our defense posture.
Right.
What are we going to do next time?
I know. And I do know that my Arthrex rep, anytime I'm at the stage where I'm putting in an OCA, if I look over my shoulder, I know he's staring at the ceiling because he just is like, if I just look up here, everything will be fine.
It's like,
You know,
mom,
just-
mom can't watch your sporting
can't
events,
watch.
right?
Exactly.
Like, I'm going to look away. Like, you missed the finish.
yeah. He's like, just tell me when it's there.
We
Just-
do
just
close
tell
our
me.
eyes, though, at the
Yeah.
end. I always go, I'm Italian in Irish,
Yeah.
but I'm Italian, the name ends with an O,
Yeah.
DeBerardino. I go, oh, it fit fine.
Yeah.
But the pulse
Yeah.
lavage is probably the most practically important thing.
Yeah.
Because before we drilled it, and before we had biologics, before that was even a word in orthopedic sports medicine, I've pulse lavage since I did one of these, I think, with Russ Warren. We tried the bulb syringe, and we're like,
Yeah.
pulse lavage, let's use pulse lavage.
Yeah.
And people use that carbon
Right.
jet thing.
Yeah.
I've used
I
it
believe
once,
Dr.
and
Cole-
and
yeah.
it works well, but so does mundane. I mean, everything's expensive already. We try to
Yeah.
mitigate costs. I'm in a university system, so pulse lavage is not free, but it's ubiquitous.
Right.
Suctions, you already have suction tubing. I take the tubing off. I'm like plastic rubber
Yeah.
tubing because you get a good seal. I put my hand around it, and it's sucking just water out. It's not sucking air in from the already
Right.
fluidically demised areas. It's sucking it all out because that's the only where the suction can go is in and out because we've drilled it
Right.
and pulse lavage there for like 5 minutes. That's the longest part of the
Yeah.
case, pulse lavage.
Yeah.
But if you skip that step, like I have a tall LSA, licensed surgical assistant, it's like, all right, pulse lavage is over. I go, no. Let's talk about the kids. Let's talk about the weekend. I want to
Yeah.
see clear fluid come out.
Yeah.
No, it's like you can do the quick wash. You can do a regular wash. You
Right.
can do the regular wash.
Exactly.
I think it's critical.
Today's episode is proudly supported by Nice Recovery Systems and the Recovery Shop. Nice Recovery, renowned for its leading iceless cold compression machine, has partnered with the Recovery Shop, a premier platform for postoperative products. This collaboration ensures unparalleled patient service and access to the flagship Nice Recovery machine.
Elevate your recovery experience with the finest support and innovation at shop-recovery.net. For the Nice Recovery machine, you can see more about that unit and the innovation going on here, right in our backyard in Boulder, Colorado, at www.nicerecovery.com.
Agree. So that was a really awesome overview of the
Yeah, thank you.
OCA,
Yeah.
the osteochondral allografts. We do want to just briefly talk about the off-the-shelf options. So
Absolutely.
do you use the Arthrex Cartiform off the shelf? If so, what are your indications to do that over an OCA?
So Cartiform is great. I call it, when it first came out, I'm like, it's my just-in-time cartilage repair. It's just off the shelf. It's right over there. We always have some available. So it's great for the, he's got a trochlear lesion. 6 months since I saw him and did the initial nanoscope, staging scope and pictures, or he came in from Germany or somewhere else from another, when I was in the Army, from another post somewhere, and it took a while. We're not going to repeat the MRI, and we're not going to slow down the freight chain. We got Cartiform. Cartiform for me is best for I use all soft tissue anchors now and do a bridging technique to the little holes. I always skip one hole. We usually take 4 anchors, and we'll drop in a trochlear cartilage Cartiform right in. I mean, it's perfect.
Okay.
You can get it, you can nail it. And it doesn't have to be perfectly round. Usually they're kind of made round because I'm a simpleton. I can't match a trapezoid to a trapezoid. Things will go amok. And round just seems nicer. But it's a great fit. Trochlear is really hard to do with an OC. We all
Yeah.
do them. I do patella trochlear. I just gave a talk at Anna and another AOSSM instructional course years ago about it. So we're doing more and more of those, but we don't like to do those. And Cartiform, like I said, for me in my hands, because I'm a big OC user, is for that.
Yeah.
Oh my God, there's also another
There's an
lesion.
addition.
Or if I'm doing a
Yeah.
multi-leg with a meniscal transplant and an HTO, trochlear,
Right.
or a patellar facet. I don't have a patella. Like, I'm going to fix it.
Right.
I'm there, fixing the kitchen sink.
Yeah.
They're getting a disposal too.
Yeah, I think that example of you're in there and you're doing an OC plug, and a condyle, and then you also have to address that
Anything
trochlear
else.
lesion.
Yeah,
or,
it could be. I've done
it's a
patella.
great
I've done
option.
plateau with a
interesting.
Cartiform.
Yeah.
You can just glue it in because it's under the anterior leading edge of a meniscal transplant.
Sure.
You have total access
Yeah.
to it because you don't have a meniscus. I'm like, glue that little puppy in. It gives it. It's like it makes the meniscus have a stable substrate, level. It doesn't have a little fallen or a creaky 2x6 floor underneath the new meniscus. It's great.
How do you fixate it if it's on the plateau?
You can drop a suture anchor in, and you can come in at whatever angle you can. It doesn't matter because the cartilage is going in like a disc, and the soft tissue all suture anchor is just anchoring it down. They can be off axis, if you will, because the cartilage doesn't know it's being pulled down and to the right. It's going to fit snugly in the shape you cut out. Because I do it with a blade, arthroscopically, or open. I mean, because sometimes these are they're OCs, so
you already got a little.
and then I do the anterior horn of the meniscus. I do everything arthroscopically I can, but then the anterior horn of the meniscus is off. I open the knee, do the patella, the condyle, and everything else, and I do a little bit of Shelbourne-esque surgery at that point. A little open, because you can.
Exactly.
Yeah, no, 'cause you
Good.
can. Well, what about osteochondral autograft? So any particular lesions, as far as size, location, that you're leaning towards the auto?
So I always consent people for it. We're doing an allograft. We've got it. It came in. We got it approved. But we also may augment with an autograft. And a couple reasons I've used it. I've used it, and I forget who I should give credit to this for. I used it for somehow there's a misfit. It doesn't quite look like it's solid. I'll use an autograft plug as the Yankee Workshop, a non-hardware driven wedge.
Okay.
To get it at the corner, it's a little, there's a little grade 2, 3 there. We weren't going to cover it. Now this plug's not quite sitting good. And autograft from usually the supralateral flare, the lateral condyle, little arthrotomy, or we're in an arthrotomy setting already. And I'll use that as a shim. It'll almost look like a little snowman graft, a little short T-Rex arm. But it fixes it snugly without adding hardware to the mix.
Right.
And doing things you don't really want to do. And you're like, well, I can make it biologic. And that works great.
Yeah.
Because we get plugs all the time for holes in the in the notch.
Yeah.
You can use plugs to secure other things.
Yeah. Very cool.
Autographs. So autographs are utilitarian for that, and I use them de novo as if I don't have cartiform, or if I have a lesion that's deeper than cartilage, I'll try and get an autographed oats, and I always put it on the consent.
Yeah. And what technique do you do to take that graft?
If it's already an arthrotomy, I'll use the single-use tubes that Arthrex has. They're still beautiful because they're just single-use. They're ultimately sharp, and they're the right size, and they're engineered, and they're as good as they're going to be with one use. You can use the allograft oat sets to get an autograft plug. You can do that.
Yeah.
But they started, I guess the smallest cylinder drill, I think
Yes.
it's 15.
Yeah.
Maybe it's 12, but I think 15 for sure in our set. I lost one.
Whereas you can do an 8 or.
Yeah, you can do it for the OATS 2.0 set.
Yeah,
Yeah, you can
so
do 8, I believe.
8 is the smallest, so that's nice. So when you need just a shim, a little shim is probably more than adequate.
Yeah.
I think it's great.
Yeah, I love that.
So restoring cartilage defects is just one part of it, right? We were discussing before, a lot of times you're doing a meniscus transplant or a multi-leg. We want to talk a little bit about osteotomies.
Oh, I love osteotomies.
How often are you adding one, and how do you decide which patients need what osteotomy?
So I'm surrounded by learners, so I always say go in assuming we're doing an HTO and prove we don't need to. So we go at it like that, and it makes it so we don't miss one and go in the OR like, dude, that's an 8-degree correction.
Right.
It's more than 6. 6 is my cutoff. I'm like, if it's 6 or more, we are doing one hands down. If it's 5, I might do it because I'll send them to Dan Cooper or someone, and they'll go, Tommy, you should do an HTO. And then it's planted in everyone's head. I go, we're doing an HTO with your medial condyle. That's what I did to my last superstar D1 athlete. So HTO with an OC and a meniscal transplant is a common triad, and then whatever ligaments we're also revising or doing primarily. But I think it's critical because you've got to offload the environment that went south. I mean, you can't say, well, you got the medial condyle lesion because you have a chronic ACL and PCL. We know that's probably true, but are we really going to count on our reconstructive technique that we know is not perfect to restore the native biomechanical environment in the medial compartment? I want that graft we all do to be the longest bridging technique it
Right.
can be.
Yeah.
Doing an osteotomy for a medial femoral condyle lesion, if it's not staged and it is concomitant, it is the same rehab. Toe touch weight bearing, 0 to 90, quads, everything else. So it's not a
not a big
morbidity
change.
adder
Yeah.
to the patient's rehab dreams.
Yeah.
Exactly.
But it does for us give us a little insurance policy that we've done everything we can to make that environment as nutrient and biomechanically rich as possible. So.
Yeah.
That makes sense.
Yeah. Any questions about osteotomy that you want to add?
No, well, I mean, you mentioned, you said HTO a lot
Yeah.
for patellofemoral. I think a lot of people are talking about TTO. Is that a
TTO,
big portion
yeah.
as well, too?
Yes.
And then how much are you doing DFOs?
So DFOs are a little more morbid, especially in a high-end athlete. So I'm really picking and choosing those. And I don't find in my 30 years of doing them now almost that you have to do a lot of DFOs for patellofemoral in these patients. It's not the young patient that's totally dysplastic with torsional
Right.
three-dimensional problems. These people have survived that.
Yeah.
They now have a durability issue. They've just worn out their tread. They need a new Indy tire for the race. And that's what we give them. So I love doing a TTO, whether I'm going to change it or not. If there's a reason to, like I have a distal incision from a central BTB harvest, I'm like, we're using that same incision. I will lift up the garage door of the trochlea, of the tubercle,
Yes.
and I'll take the patella, flip it north-south instead of east-west.
Okay.
And especially if I'm doing other work that's downstream and I don't have to make the total knee arthrotomy this time. I can just lift it up and through a small incision, I just flip the patella from south to north. You have to just remember where you are and what you did to the patella because you're like,
Upside down.
Yeah.
whoa, whoa.
No,
And
so
I label
true.
it. I put labels on blue towels. I go, this is 12 o'clock.
Yeah.
It was 6, but it's 12.
It's 12.
You can get
You have to
really
say it out
messed
loud.
up.
Yeah.
I know everyone says, okay, say twice, cut once, or
Yeah.
because you only get one cut.
Absolutely.
That's really
It's
important.
true. It's such an easy, it sounds so simple, but it's such an easy mistake to make.
It
Right.
really is.
And most of these people are their traumatic lesions. They're isolated, focal, well contained, and unipolar. The four mainstays of doing them in the right people most of the time, unless they're a one-off bipolar. So what does that mean? That means they usually have survived the dysplastic era. If they were dysplastic, they wouldn't be
Yeah.
the kind of patients I like to do these on D1 athletes
Yes,
and above,
exactly.
or high school athletes heading to D1. You fix what you need to fix. You have to operate as Dr. Kelly says. He goes, Tommy, you got to operate hard enough. And I go, you want to leave the room knowing you did everything you can to potentiate longevity. So I don't hesitate to do a bone cut because I'm cutting a little bone in an OC, it turns out.
Yeah,
Right.
So we're taking it out. So
Yeah.
Absolutely.
As far as post-op, do you standardly do MRIs or, how are you following?
we talked about that at our meeting just up at up the road last week, and we were talking about who do we get MRIs on? In the professional athlete level, NBA players, they get an MBA if they sneeze, right?
Yeah.
So we get a lot of, surrogate MRIs to see if they're ready to return to play. I like the nanoscope now, honestly,
Yeah.
because
Sure.
you look at an MRI and you see a little white fluid signal. It's not even necessarily a cyst. It's just still healing because you get it at 6 months. You're like, is he ready to go? Is he ready to get out on the court? And people freak out because they don't know what they're looking at. They don't know the 1,000 that I've seen before. They go, that's nothing. It's a white dot, but it's not like a quarter-sized cyst.
Yeah.
So we don't like to get them as the definitive test, but we get them when we're looking at them for a study, certainly. X-rays are great.
Yeah.
You can literally see the confluence, the vascular access channels. You can see, it looks like it's bridging toothpicks.
pretty cool.
You can see the striations, and you're like, that is fused.
Yeah.
And then, so I like a sunrise X-ray and a lateral for
Yeah.
patella. That's usually enough. And if it's a home run clinically, I don't get an MRI because it just makes people go,
Ooh, what do you
Or,
have?
to be
just
careful with the
financially
cyst.
too.
Yeah,
who's
It's
paying
like,
for it? Yeah, if it's the Spurs, I mean,
Right,
it's not a
sure.
problem. That's just a bad
Yeah.
lunch.
Yeah.
So they get an MRI on my knee
Yeah.
to make sure it looks like mine. No. So the point is, we do get MRIs. They're important, but we don't get them that often. We only get them if there's a problem. Recurrent effusions and pain, get an MRI. And then look back at the pre-op MRI or MRIs that you have in the past. But opposite knee X-rays are good still. I mean, those
Yeah.
are the good template in most of these people because they are traumatic. They aren't like diseased lower extremities where they just look as
Right.
bad as the other one. These are like
Yeah.
athletes in general that I try to pick that are, for the volume of these, that have a normal side, hopefully, and you can compare it.
Yeah.
So for post-op, you kind of have talked about it as we've gone along in terms of whether or not you let them weight bear and kind of range of motion. So can you talk a little bit about post-op? Do you
Right.
do CPM? Do you have any range of motion restrictions for patellofemoral?
So I mandate that they get 0 to 90. They get it the next day. I usually see patients out of town the next day. They stay in a hotel. They come in and they go, okay, you can leave in a day or two. They go down on the Riverwalk, hang out, catch a rehab sequence with our guys, and then know you're on the right track. So we move them right away. 0 to 90 is the limit. If our trainers in our place where they have the same epic thing, they can see my notes and I go, this guy's doing great. He's already going 110. They know de facto they can go past 90. I want them to definitely get 0, mostly just like we always say, hyperextension if they have opposite side hyperextension right away. I brace them in a ROM brace is in full extension. They can walk right away and they're moving their knee. I've never used a CPM. We got rid of CPMs when I was a fellow at West Point. We just put them in a storage room and then they were gone one day. Because we, in this current environment, I can't get many people to pay for it. I can't get them to use it. If you or I put it on, we know it fits great.
Yeah.
If the nurse does it the next morning, they're like, it's set 0 to 90, and they're going 20 to 70. You're like, no, that's not what we wanted. So I'd rather make them responsible, and I talk about them owning their knee. And I go, you got to own your knee. This is extension. Put a block, a towel under your ankle. Let it sag like a suspension bridge. Flex it over the side of the bed 5 times a day for a minute. Do cycles. Lift it up until you don't need a spotter. I say, this is your therapist, and this is the patient. Take care of yourself.
Exactly.
And I watch them do it while we're talking about where you're going to do rehab in North Carolina.
Yeah.
And then, they walk out and they go, I got this. I go, you got this. Just wear the brace for 2 nights in bed, 6 weeks for ambulation. And I do for the super athlete that comes in and their quad never went away because we don't use a tourniquet. Their quads fire right away. I'm like, all right, you are a straight leg brace. You can go from bed to bathroom, lock your knee out, and just walk to the bathroom if you get up in the middle of the night to get a drink of water. You don't have to put your brace on. But be religious outside. You're protecting yourselves against all the rest of us that might go, hey, you look pretty good, Jim.
Exactly.
You're like, whoa, he's a little top heavy. and then they fall and they call me. I go, did you have your brace on? And if they have their brace on, I'm like, whew, knee's okay. I don't care about your elbow.
Exactly.
Yeah, absolutely.
I think it's important.
And then if they fall, you're just like, it is the
They all
worst sort
fall.
of thing.
It's a text
fall.
message or a
Worst
call.
fall
You're like, Dr. E, just let you know, Mrs. Smith fell.
It's
You're
like
like,
the last.
it's like I was at 5 o'clock. You're
Yeah.
like, do you want her to come in? I go, no, I got a plane ride.
No.
She's coming in Tuesday. And I go, I pray she can put her brace back on.
I know those are the hard things,
Put your
but
brace on.
just skirting back quickly to if you are having some concerns and you get an MRI or they fall or something like that, are you then going, okay, let me stick the scope in and actually see, touch, feel? Or how
I
do you
do a
handle
fair
that?
amount of second look scopes because these are multifactorial, multi-involved patients, and the patella is one issue, the arthrotomy is an issue, the gravity of the whole body. They get a little bit of stiffness when you do a multi-lig and a HTO. I mean, the body can only handle so much. So I'll go in early. I don't let them wait and, let's give you another 6 weeks. I go in early because I can win the battle instead of fight the war.
Yeah.
And I'm super aggressive.
Okay.
I do an arthroscopic, and then I'll use a real scope because I'm doing too much. I need every tool that we don't as yet quite have in the nanoscope world. We've got little things, but it's like breaking out of prison with a spork. If I got to do a total synovectomy, I need big stuff, big shavers and Arthrex big stuff. But the panoscope's great because I can get to the back of the knee and do posterior capsule releases.
I haven't had my hands on that yet.
Oh, I used it at the TPC course
I
that we were
feel
at.
like I got rid of some cataracts I didn't know I had. Really?
Every other
I'm looking
case,
at the whole mountain vista, not just the hilltop.
every other case, I just say to my Arthrex rep, I say, why don't I have this camera yet? You know what would be really great here, Kyle? If I had the pano.
Yeah, why don't you bring in the
He's
pano?
like, I'm working on it.
It's going to be de facto kind of base of industry in a year or two.
Yeah.
People are gonna be like, I can't do
No,
it
it's
without
exciting.
this.
Yeah.
It is really,
In
really
knees
exciting.
especially, hips too, because I feel like I can not ever, like, where's the other
Around
side?
that corner. Yeah, no, that's pretty cool.
You can dial it up to a 70 and pull it back to a 0. It's just, it's kind of cool. It's what we all wanted.
Yeah, I'm
Yes.
sure it's here somewhere.
They've delivered.
Definitely.
Oh,
it's here
it's here.
somewhere.
Okay, we'll find it.
Yeah. So I think second look scope for a utilitarian reason
Okay.
is another reason to go back in. And you can win the battle, like I said. You get them back quicker because if, we had a talk yesterday from Bertrand, France. Big advocate of the brain linked to the knee and quadriceps, arthropometric shutdown. And if you don't get full extension back right away,
Terrible.
and Dr. Shelburne gave his practical appearance on this yesterday at Herodicus, and if you don't get full hyperextension or full extension at 2 weeks, you likely are going to be fighting that battle forever.
Ever.
No matter what we do. So I'm hair triggered, go back in, because you know, everyone gets a confidence boost, the psychologic part of it. They're like, I need to get my quads back. And if you have quad inhibition, there's no rehab for a patella.
No.
And that could be a disaster.
Yeah.
Yeah, so important. It's like, I think what just scared the living daylights out of them about the extension.
And some
I do.
PTs, I mean, not you and
What?
your people
What?
that you have, but some
Oh, yeah.
PTs also don't recognize it. They'll come in and be like, oh, they get straight at PT. I'm like, just sitting at -3 right now in my clinic,
Yeah.
and this is not okay. I need you straight all the time,
Yeah.
not just after they stretch you for an hour.
Or you
right?
walk in
So-
and they have their jacket under their knee. I
Yes.
go,
Totally.
never. I walk in and
Yeah.
I just was taking a spider off them. I'm like,
Yeah.
oh my God, take that out.
Yeah.
And the mom goes, oh, I did that for her. I go, stop
No.
being that kind of
It's
mom.
like-
Be the other kind.
Yeah.
Be my mom.
Be mean.
Get your extension back yesterday.
Yeah.
It's so important.
It really
Yeah,
is.
be me as a mom when I'm like, you're fine.
And put that towel under there, put a wet washcloth. I go, no.
No.
Bend that knee over the side. She can't bend her knee or he.
Yes,
I'm
she
like,
can.
watch.
Yes,
They're going to
they
do it
can.
themselves. I make it do them themselves when
Yeah.
we're talking about like logistics. And they kind of go,
Oh,
same thing works. I go, it's a good pain.
Yeah.
I go, I've never felt it, but it's a good pain. Because you're stretching your quad. I mean, who am I to say that's not painful? It's
Yeah.
painful. But
Yeah.
once you
It's
tell
nece-
them,
it's so
put
important.
my hand on the thigh, I say, put your hand on your thigh. That gives you proprioceptive feedback. And they're like, oh, it's been cramped up
Yeah.
for 3 days over the weekend. And I'm like, miracle of miracles.
It's
And
just
then they're
so
like doing it. I go, okay, you can stop now. Let's get you dressed up, put a bandage on, and
Exactly.
Yeah.
teach you how to use your brace.
Exactly.
So
Absolutely.
I win them over. They start like crying,
Yeah.
and then they come out. Thanks, doctor.
yeah.
That means you've done
the most
good.
rewarding
I tell
day.
people it's the easiest thing for me to walk in there and say, "You're doing great. Take care. See you in 2 weeks." If I'm making you cry, do you think I want to make you cry? I don't want to make you cry.
Because
but-
other people
but-
are coming in next, and they're like, I'm not going in there.
Yeah.
Exactly. I don't want to see that guy.
Chamber of torture.
Exactly.
We had when someone graduates, they're like the end of ACL rehab, whatever. They get this like medal, and it's got like it's pretty neat, and
That's
we give them a certificate and stuff. And I've like recently we had one of our patients who was like walking out strutting into the office, and they like literally heckled somebody in like crutches, and they're like, "I'm done."
That's good peer pressure. You know, I am old school. I mean, I like private exam rooms, but when I have a difficult case in a team
Yeah.
environment, I love the
Yeah.
6 table. Everyone's facing each other.
Yeah.
I'm on a wheeled stool.
It's
and
helpful.
You know,
It is,
there's a team. I mean, it's a team sport, good and bad,
Yeah.
good days and bad days. So
Yeah.
when they're all going through the same thing at different phases, there's nothing like seeing like, oh,
Yeah.
I'm going to be like that next week or in 4
Exactly.
weeks.
Yeah.
You know, and it breaks the code of like privacy. But you
No,
know,
but I've done that where I've
talk
asked
about everything
people,
in a group.
Yeah.
So
like
why not
where I'll
that?
have someone in my clinic that is, over the hump and almost like done, and I'll be like, hey, there's a girl down the hall that is like just in the midst of this. Would you go say hi?
Yeah.
And patients will do that, and
Yeah.
it's really impactful.
It's like a real-time sports psychology.
Yeah,
and
it
it's
is.
like people to people, peer to peer. I
Yeah,
love that.
me
I mean,
too.
it's really gets good dividends.
Yeah.
Important.
Hard to measure. Makes us feel good.
Exactly.
Makes patients look better.
Exactly.
Good.
Awesome. Well,
Yeah.
thank you so much. This
Yeah,
was an
this is
awesome
so
conversation.
amazing.
Yeah,
Yeah.
it was really great.
Been a-
We really appreciate you taking
My
the time
pleasure.
out of your
Yeah.
busy schedule to be
I've
here
been
with
looking
us.
forward to this. I was like,
This
oh,
is so
good. I got
exciting.
picked.
Yeah.
I've been chosen.
Now you can tell all the other people because
Yeah.
always after this meeting we get a couple messages like,
Hey.
"Hey,
What about
can I
me?
be on your podcast?"
Talk about big
when they
toes.
see when they see the awesome guests we have. So thank you so
Yeah.
much.
As
Thanks.
long as you don't want to talk about hips, we're just like, that's the one we put
I do
off.
hips, but I don't even
Yeah.
advertise. I'm like, somebody's got to
Yeah.
do them. I'm like, I do the low-hanging fruit.
Exactly.
Yeah.
14-year-old gymnast with a labral tear.
Yeah.
I'm like, no bone. I can fix that like a meniscus or a labrum, and we're done.
Exactly.
That's good. All right.
Yeah, well, thank you so much.
Thank
We
My
learned so
pleasure.
much.
Thanks.
Thank you for listening to this episode of the Sports Docs podcast. We hope you enjoyed the discussion as much as we did. Make sure to subscribe on Apple Podcasts, Spotify, Amazon Music, and on YouTube to stay up to date on all things sports medicine. If you like what you hear, please consider leaving us a review or comment. You can also reach us by email at thesportsdocspod@gmail.com or find us on Instagram at thesportsdocspod. We love hearing from you.